Hi, everyone. It's Bill Hahn, and I have the pleasure today of introducing today's speaker, Sheila Stewart, who I am very fortunate to count as one of my long-term colleagues and friends. But before I introduce Sheila, I wanted to say a little bit about today's lecture that is the Jean and Jerome Pearlstein Lecture. In 1994, Dana-Farber trustee Jean Pearlstein and her late husband, Jerome, or Jerry Pearlstein, endowed this lecture to further excellence in education for the next generations of physicians and researchers. The Pearlsteins have a long history of commitment and involvement with Dana-Farber and the Jimmy Fund. Jean has been a DFCI trustee since 1987, and she's former president of the Friends of Dana-Farber and a longtime participant in the Boston Marathon Jimmy Fund Walk. Jerry served on the Jimmy Fund Advisory Committee and co-chaired the Jimmy Fund Marathon Walk Pace Center Committee from 1992 to 1994. Their recent contributions to the Mission Possible campaign and the Dana-Farber campaign established a lounge on the third floor of the Yawkey building and a space in the Ripple Effect display in the Chestnut Hill location. We are forever grateful for the Pearlsteins for their steadfast dedication to Dana-Farber's mission, and we are honored to hold this annual seminar which bears their name. Jean is a energetic and involved trustee, and I've had the great pleasure of interacting with her quite a bit. So Jean, thanks so much for endowing this lecture and for participating. So it is my pleasure to introduce my old friend, Sheila Stewart. Sheila and I were postdocs together in Bob Weinsberg's lab many years ago. She's gone on to a fabulous career at WashU St. Louis, where she's currently the Gertie T. Corey Professor of Cell Biology and Physiology. She has a number of other titles at WashU St. Louis. She's the Associate Director for Basic Science at the Siteman Cancer Center and the C4 Program Co-Director also at the Siteman Cancer Center. Her work over the years has been focused on a number of different topics related to age and cancer and the interactions of age-related processes to the pathogenesis of cancer. And I think she's going to tell us a little bit about that today. And the title of her talk is Getting Old Stinks, Age-Related Stromal Changes Drive Tumor Progression. So Sheila, thanks so much for spending time with us, and we're looking forward to your lecture.
Thank you, Bill, and thanks for the invitation, and everyone who's been able to zoom in wherever in the world you might be, for the opportunity to share our work, in which, as Bill just alluded to, has really been interested in understanding how age-related changes within the tumor microenvironment contribute to tumor genesis. And really the reason that we have been interested in this question is this graph right here. Age remains the single largest risk factor for the development of cancer, regardless of cancer type and regardless of whether you're a male or female. And when you see a graph like this, I think you do have to take a step back and really ask, what is it that's happening over the decades of our life that lead to not just a subtle, but a very rapid increase in tumor rates in that 5th to 6th decade of life? I think the answer is a complicated one. Cancer, in fact, is a complicated set of diseases. And I think part of the answer lies in the fact that it is a disease of multiple mutations. And when we consider the fact that our mutations are really occurring in the robust DNA repair mechanisms in place to slow it down, it's just going to take time, not just for the mutational load to cross some magical threshold to take a normal cell to a tumor cell, but also that right combination of mutations that can drive the transformation process. The question then lies is this enough? Is this the single driver that leads to that rapid increase in tumor genesis in that 5th to 6th decade of life? And I wouldn't be setting you up for this if I didn't think something else might be in play. And we were really inspired, if you will, from work from Judy Campisi many years ago, and the possible role senescent cells might play in this transformation process, and then the emergence of cancer in that 5th to 6th decade of life. As with mutations, senescent cells are also known to accumulate in every tissue that's been looked at to date. And the reason that we became so interested in these cells was the fact that when one looks at their phenotype, if you will, they're able to recapitulate every factor that's been ascribed to a cancer-associated fibroblast, depending on the system and the tissue that was being looked at. It certainly can directly affect tumor cell proliferation. It can alter migration and invasion characteristics of already transformed cells. They have the capacity to affect angiogenesis. And in addition to that, they're able to create immunosuppressive environments, often locally around themselves. And so certainly these cells, as well as CAFs, have the potential to drastically change the tissue and influence transformation rates. But I think that really the strongest data to argue that these cells play an important role in spontaneous tumor formation came from Darren Baker's work that was published a few years ago. I don't have time to really go into the genetics of the mouse that Darren Baker's group actually created, but suffice to say, through an inducible suicide gene, one's able to eliminate senescent cells systemically throughout the animal. And in addition to looking good, you can see that the animals with plus AP, this is where senescent cells would be killed. Obviously, the fur looks better, they're bigger, but importantly for today's discussion, if you look at the graphs that are over to the left, it doesn't matter if you're a male, a female, it doesn't matter if you are on a pure B6 background or even a mixed background. By eliminating senescent cells systemically throughout the lifespan of these animals, one is able to significantly delay the onset of spontaneous tumor formation, really leading to the hypothesis that these cells do in fact play a critical role in early transformation, if not progression. And so how might these cells do that? I think, again, this is a complicated answer, but we've really focused on senescent stromal cells and how they might be involved in this increase in tumorigenesis, again, in the later decades of life. Basically, senescent cells, as with CAFs, basically make everything yummy, I like to tell people, that you can imagine if you're a tumor wannabe. They make a large number of mitogens. Obviously, I've already said they can directly drive tumor proliferation. Many factors that are known to modify the extracellular matrix. And they make an entire cadre of immune factors, cytokines and chemokines, many of which have the capacity to create immunosuppressive environments locally around these cells. And so several years ago, we got quite interested in really the molecular mechanisms that led to the increased expression of many of these factors. And this was work from an early graduate student, Elise Alspach, who was able to go on and show that activation of the p38-MK2 stress kinase pathway was able to lead to the stabilization of many of these senescence-associated secretory phenotype, or SASP mRNAs, and that this mRNA stabilization then led to increased protein expression. And what was interesting is, using both genetic as well as pharmacologic approaches, Elise was able to show that by limiting the activity of the p38 pathway, she could significantly blunt the pro-tumorigenic effects of senescent fibroblasts. And interestingly, she also noted that she could also limit the pro-tumorigenic potential of many CAFs. Remember, I already mentioned that from a phenotypic standpoint, CAFs and senescent fibroblasts were able to really recapitulate the same types of phenotypes. And not surprising, in the end, we also found that many CAFs also activate the same pathway. And so we've done a number of experiments looking at primary tumor growth, primarily focusing on breast cancer. And given this observation that the p38 pathway was also important in CAFs, not just senescent fibroblasts, Bhavna Maruli, a subsequent graduate student in the lab, became quite interested in asking the question whether or not stromal cells within the metastatic setting of breast cancer could also be involved in progression of the disease. And so she went on to look here. I'm just showing you one stain, but obviously within the paper you can see many more, where she was able to show that the p38 pathway was in fact activated specifically within stromal cells within the bone of patients with bone metastases. And so we decided to set up a couple of preclinical models to really try to get at this and ask the question, could we limit p38 activity in the stromal compartment in the metastatic setting to limit tumor progression? Now, unfortunately, in the mouse, there is not a spontaneous model of bone metastasis, and we really wanted to focus on this because in the setting of breast cancer, bone is in fact the most common site of metastases. So for most of our experiments, we actually utilize an intracardiac injection model. And the advantage of this particular model is it allows us to look at the second half of metastasis, if you will, the seeding event, both within the bones as well as widely across the visceral organs. And so what Bhavna did when she first got started on this project was to basically set up a preclinical experiment where a breast cancer line was introduced into the animals. And she's subsequently gone on to do this in many, many more lines. But in the interest of time, I'm just going to show you one of those particular lines. seed these cells into the visceral as well as the bone, and basically take these animals and randomize them onto what we're going to call for today standard of care, PTX or paclitaxel, which is in fact used in the clinic in the metastatic setting, or onto an orally available P38 inhibitor, and simply ask the question, what happens to tumor burdens in these animals on these various treatments? And so what I'm showing you over on the right is actual tumor burden on the y-axis there in either the bones, or on the left, we're looking specifically at the visceral organs. And what we were excited to see was that P38 as a single agent, those are the black triangles, were in fact as effective as paclitaxel, which are those squares right to the left, at limiting tumor growth, again, both in the bone as well as within the visceral organ. Now, I started my lecture out saying that I really was interested in focusing on potentially CAFs and the stromal compartment as well as senescent fibroblasts. And clearly this is a pharmacologic approach that's going to hit every cell in the animal's body. So to establish what the actual target was of these drugs, we really took two different approaches. Shown over on the left is an in vitro experiment where these tumor cells were treated either with the P38 as a single agent, that's the black bar, or with that paclitaxel, that's the blue bar. And as expected, these cells are in fact sensitive to paclitaxel, but completely insensitive to the P38 inhibitor. I think the more convincing data, though, is actually shown on the right. We took an shRNA approach to limit P38, or deplete P38, I should say, in the tumor cells, and then introduce them or control cells, again, through that intracardiac injection into the animals. And I think what you can see from the graph on the right is that these cells really couldn't care if they lose P38. Those are the square, orange squares. They grow just as well as control cells. So certainly this doesn't prove that we don't hit the tumor cells at all, but we do in fact think that it suggests that the primary target of our pharmacologic inhibition of P38 is in fact the stromal compartment. Now, I mentioned that when Elise was a graduate student, she had actually shown that it was P38 activation and its ability to stabilize mRNAs downstream of the MK2 kinase that led to the increase in many of these senescence-associated factors that were also present in CAFs. And this is where we had a bit of serendipity stepping in, and there was a local company in St. Louis that had been developing an MK2 inhibitor for rheumatoid arthritis. And we decided to start working with them because this drug was showing very low toxicity in their large animal studies as well as in their normal volunteers. And so we wanted to ask, could we recapitulate the same phenotype with the MK2 inhibitors that we had seen with the P38 inhibitors? And so we took a very similar approach. In this case, I'm showing you here where we used RNAi to limit MK2 expression within these tumor cells. And as with the P38 approach, I think as you can see in the graph there, these cells grow at equivalent rates, whether we've depleted MK2 shown in those triangles versus the control cells. And then similarly to the P38, when we used an MK2 inhibitor specifically, what we were able to show is that we can again significantly limit tumor growth. Here I'm showing you specific growth in the bone, but we saw the same thing when we looked in the visceral organs. So we were actually quite excited that we could show that both the P38 inhibitor as well as the MK2 inhibitor, again, as a single agent, was as effective as paclitaxel at limiting tumor growth, but also slightly increasing survival over control animals. But what was really interesting about it was when we looked at these animals, they actually, in the words of my graduate student, were much happier than their litter mate controls that were treated with vehicle or animals treated with paclitaxel. And by happier, what she meant is they were much more mobile. I think I already mentioned that this model that we use does put heavy tumor burdens within the bones, and quite often what ends up happening is these animals become very limited in mobility, often fracturing their hips, which makes us lead to humane endpoints to end the survival curves. And this observation really made us start thinking about the clinical situation. I've mentioned already once that bone is the most prevalent site of metastasis in breast cancer. And unfortunately, when patients develop bone metastasis, there are a large number of skeletal related events that impact quality of life, not the least of which is pathologic fracture shown there in the middle square. Now, this has been primarily dealt with in the clinic by the advent of bisphosphonates and then more recently denosumab. And in fact, these two drugs together have been able to limit these terrible side effects for these patients by over a third. And the way that this works is that the bisphosphonates, when given specifically, are able to covalently link, if you will, onto the mineralized bone surface. And as the osteoclasts, which are the cells that are charged with resorbing or eating the bone, if you will, begin to resorb through the bone, the bisphosphonates are taken up and actually lead to death of the osteoclast, thus preserving the bone integrity. Unfortunately, while it is able to preserve bone integrity, it doesn't slow tumor growth down at all. And actually, tumors continue to grow if patients don't also receive chemotherapy. What was interesting for us is it had been known in the literature for some time that the p38-MK2 pathway actually plays a very important role, not only in osteoclast differentiation, but also osteoclast ability to actively resorb bone. And so we decided to go back to our animal model and ask whether the reason these animals were much more mobile is that their bones were actually in better shape. So what I'm showing you here is a trabecular BVTV. For today's discussions, just think of it as bone density, if you will. And these circles that I'm showing you is the bone density for this particular strain of mouse. I'm not showing you the density for animals that were treated with vehicle alone, because I'd have to show you basically fake data, which I don't like to do. These animals have such large holes in their bones that often we can't draw contours and get the bone density for them. So you can imagine that their bone density is somewhere close to the bottom, given they have holes. And what we saw when we looked then at our animals under our various treatment was, in fact, remember paclitaxel is able to limit tumor growth, and the bones clearly are doing better than the vehicles would be in that they don't have holes. But what we thought was quite exciting is both the p38 inhibitor as well as the MK2 inhibitor, again as single agents, are able to completely return the bones back to animals that were not receiving, that did not have tumors. So that is this triangles and the diamonds. And interestingly, this was the same effect as zoledronic acid, which is one of these bisphosphonates. However, unlike bisphosphonates, I already told you that in patient populations, they are not able to limit tumor growth. And that is in fact true in our animals too. This square that I'm showing you in the middle here is actually tumor growth for animals being treated with zoledronic acid. Their tumors grow at the same rate as animals with vehicle. Again, we can protect the bone, but unlike what we see with the p38 inhibitors, again, it doesn't limit tumor growth. And we're quite excited that this work has now led to a level 3 DoD grant that is going to fund a clinical trial in the metastatic breast cancer. And we're working very closely with our clinical partner, Cynthia Ma at Washington University, as well as partners at the Mayo Clinic and also Kansas, to actually enroll patients on these inhibitors. So we like to say at this point, we basically have a 2-for-1, if you will. The MK2 and p38 inhibitors are able at one level to limit the stromal support of tumor growth, both within the bone as well as the metastatic lesions, the visceral organs, but also is able to limit the osteoclastogenesis that leads to the bone loss that we see in patients. Now, this work actually got us really starting to think about what's happening in the context of patients that are being treated with chemotherapies. Certainly in the context of metastasis, what's thought to primarily drive the bone loss are the tumor cells themselves. In fact, this is referred to as the vicious cycle, where tumor cells go into the bone, release factors that drive increases in osteoclastogenesis, which resorb bone, releasing latent growth factors, getting more tumor growth, almost a feed-forward loop, if you will. But certainly, patients that are metastatic to the bone are not the only patients that lose bone following treatment. In fact, bone is lost in patients, or I shouldn't even say patients, I should say individuals that are going through menopause. And this is in fact because estrogen plays a very important role in bone homeostasis. In fact, patients that are currently undergoing early menopause can lose up to 2% of their bone mineral density per year. And this is recapitulated in the animal models. Here I'm showing you data, again, looking at bone density of animals that have undergone a hysterectomy, OVX. They also are able to lose bone. And so we often use this as a model for looking at how estrogen affects bone integrity. And so the reason that people think that patients that have primary breast cancer disease and are receiving chemotherapy, in fact, lose bone is because estrogen talks to the major players in the bone. They talk to the osteoblasts charged with mineralizing bone, talk to the osteoclasts, I've already mentioned, they resorb bone. It also talks to osteocytes, which really are the mechanical sensors and orchestrators of communication between the osteoblasts and osteoclasts. And as I think many people are aware, chemotherapy is known to directly affect ovarian function and can lead to estrogen deficiency, hence leading to bone loss. And this is probably even better illustrated when we think of patients that are on aromatase inhibitors. So aromatase obviously is an enzyme that is in the pathway for estrogen production. And often patients that have ER positive disease will be put on aromatase inhibitors to limit their tumor progression. And perhaps not surprising, they lose even more bone than patients that are in early menopause, upwards of close to 3% of the bone mineral density. And so it's been thought, and the reviews often state, that estrogen loss downstream of chemotherapy really is the major driver of bone loss. However, we always thought this was kind of an odd conclusion, because if you actually look at patients that are being treated with chemotherapy, they lose a lot more bone than patients that are on an aromatase inhibitor, really raising the question, where is this extra, if you want to call it extra, bone loss really coming from? And so we wanted to actually address this question directly. And I mentioned already that the mouse is actually a pretty good model for looking at estrogen-derived bone loss. So what I'm showing you here again is bone density on the left. Those triangles are OVX, again, a mouse that's undergone a hysterectomy, and that's the data I had already shown you. They lose bone. But animals that are treated with doxorubicin, we see the same thing with paclitaxel, and I'm not showing you that here, lose a lot more bone than animals that have lost their ovaries. Again, similar to what we'd actually see in the patient situation. And so when we were doing these experiments, we were really taken back to our observations from years earlier, in which we had been looking at what the effect of senescent cells were within the bone. And we had actually shown many years ago that chemotherapy, which is probably one of the best ways to induce senescence, robustly induces senescence in osteoblasts. Those are the cells charged with mineralizing bone, leads to increases in the senescence-associated secretory or SAS factors, many of which are known to influence bone homeostasis. Interestingly, when osteoblasts undergo senescence, basically they stop mineralizing bone. So I'm just showing you a picture here, and that red there is a way we measure a mineralized bone. And the well underneath, I promise you, has osteoblasts, but they're senescent, and they completely lose the capacity to mineralize bone. What's interesting about the bone is osteoblasts or live in harmony, if you want to think of it that way, with the osteoclast. They're in constant communication. And so your bone turnover is matched both by resorption and mineralization. And it's known that osteoblasts can drive osteoclastogenesis. And so we knew that the presence of senescent osteoblasts actually increased osteoclastogenesis. And so this really had us starting to think, is it possible that in addition to the estrogen loss that is driven by chemotherapy, was it also the activation of senescence within the bone that could contribute to the bone loss that we see following chemotherapy? So we decided to look at this directly. I'm showing you data simply from doxorubicin, but we see the same thing with taxanes. And what I can show you is that when we treat animals, in this case with doxorubicin, we see increases in what we call senescence-associated beta-galactosidase, which is indicated by the blue there and graphed for you underneath. We see increases in SAS factors. I'm just showing you some of these that go up upon doxorubicin treatment. Again, many of these are involved in bone turnover. And so given the fact that we saw increases in chemotherapy in animals treated with, increases in senescence with animals treated with chemotherapy, we turned back to that mouse model that I briefly described at the beginning that Darren Baker had used. Again, this is a model in which we can supply a dimerization drug. I'm just going to call it AP for today. And we're able to specifically kill senescent cells within the animal systemically. And so we did this and just started to look at expression of some of our key markers of senescence by RNA in this particular case. So I didn't mention P16 earlier. This is a cell cycle inhibitor that's often increased in senescent cells. Upon AP treatment, these animals that are also treated with doxorubicin significantly reduced the amount of P16 that we see. In addition, many of our SAS factors, here I'm simply showing IL-6 or are also reduced. So given the fact that it at least appeared from expression profiles that we were eliminating senescent cells in the animals, we wanted to ask what's happening to their bones. And basically what we were able to show is, again, treatment with, in this case, it's doxorubicin. Those are those squares. The reduction in bone that we see is completely rescued when we supply AP. In other words, we kill senescent cells, indicating that senescence does actually contribute directly to the bone loss that we see in at least our animals that are treated with bone loss. And we're actually excited by the fact that we can actually also use now what are called senolytics. These are drugs that are known to kill senescent cells, to similarly recapitulate what we see in the genetic model, raising the possibility that this may in fact be a way to further treat patients that are actually undergoing chemotherapy to attempt to protect their bones, in addition to the P38 and the MK2 approaches that I've already described. So I've already shown you this. We were actually quite excited to see that these inhibitors are functioning as effectively, at least in our model, as chemotherapy at limiting tumor growth and protecting the bone. But really one of our goals is to really push these curves to the right. Can we leverage what we understand about this P38 and MK2 pathway and combine it with other novel approaches to increase survival? Now, the P38 pathway plays a role in many, many cells, including many immune cells. I'm just showing a few here that have known roles within their either function or secretion of cytokines. And so the first question that my postdoc Douglas Faget wanted to ask was, are immune cells important for the anti-tumor effects that we see with the P38 and MK2 inhibitors? And so what he decided to do was carry out a bone marrow transplant, transplanting bone marrow from animals that had floxed alleles of P38 into otherwise wild type animals. Flox out the P38, I'm not showing the Western, but we had over 90% reduction in P38 within the CD45 positive population, excuse me. And I think what you can see quite nicely here is that we see a significant reduction in tumor growth within the bones of these animals. And this was actually similar to what we see when we use our P38 inhibitor, suggesting that in fact, the target of these drugs is the CD45 positive population. And so I mentioned one of the things that we're interested in doing is pushing that survival curve to the right, understanding what are the cells that we're targeting and how are we changing them with the inhibitor, and can we use that information to, in this case, leverage immunotherapy approaches to increase survival. Now, many studies looking at immunotherapy are often done in the primary site. And of course, the problem with that is there's been a number of studies, a very beautiful paper by Padme Sharma, for example, showing that the immunotherapy that might be effective in a primary site is actually quite distinct in what you might find effective in a metastatic set, particularly looking at the bone in her paper. And so we needed a way in which we could look at what was changing in the context of our tumors upon treatment. And you might imagine the difficulty in doing this, particularly when working with bone metastasis, when you have a tumor, if you will, floating in an ocean of immunity in the bone marrow. How do we look at the immune cells that are actually proximal to a tumor versus those that are just in the rest of the bone? And does that actually even matter in the end? And so to do this, we decided to take advantage of what I think is an incredibly elegant system, mostly in its simplicity, and I wish I'd been the one to think of it. This is a very beautiful system by Ilaria Malachi's group that was published a few years ago. And the way the system works is one produces their tumor cells. They are now expressing a soluble M-cherry that then is able to passively diffuse into surrounding cells. And there were a number of controls that Ilaria's group had done. We've done a few ourselves as well. And this really doesn't diffuse much more than about 100 microns. So it's really a way to look at stromal cells, both immune and non-immune, that are embedded inside the tumor or are very closely associated with the outside of the tumor. And so we created this cell line and first just wanted to make sure it worked in our system. And so what I'm showing you up there in the right-hand column there is the exact same cells we've used for our other studies, now expressing the soluble form of M-cherry. And as you can see, the P38 inhibitor works is completely effective in this model. And so what we've done is to basically take these animals through endpoint on treatment, either the P38 inhibitor or on a vehicle treatment. And what I'm showing you are flow plots. And what I hope you can appreciate is, yes, we can see the tumor cells. Those are the PYMTB01 cells there that are both GFP positive and positive for cherry. But importantly, if you look at the graph to the left, I hope what you can appreciate is this really provides us an opportunity now to isolate GFP negative, so non-tumor cells that are either expressing CD45 or those that are not. And the beautiful thing here is we also have an internal control. We can get cherry positive. Those are, in this case, cells that are inside the tumor, versus cherry negative. These are cells that are distal to the tumor. And now allows us to look at them and ask, how are they changing on treatment? So these cells were isolated by sorting and subject to RNA-seq. I only have time to show you a little bit of the data and how we're using it now in this model. We saw, as you might imagine, most of the major CD45 populations you'd expect to find. We saw quite a few different changes when we started looking at the cherry negative. Those are the cells away from the tumor versus the cherry positive. And for today's discussion, I really want to focus in specifically on a macrophage population that we thought was quite interesting, that was greatly enriched within the cherry positive or proximal to the tumor. And what we saw when we started to look at these cells was a number of different changes, but primarily the changes that were really interesting to us is basically things that would kind of smell or taste, if you will, like a more anti-tumorigenic, a more M1 population, if you want to think of that. Clearly, there were significant increases in MHC class 2, for example, expression, and many indications of activation of the gamma interferon pathway. And we were really confident in this data, primarily because we had done a number of different IHC studies just to look at what was actually physically happening within these bone metastatic lesions. And what we found was that when we looked at, for example, macrophage numbers by F480 staining shown on the left, there was really no difference in the in the P38 treated versus vehicle, which mirrored what we had in fact seen by our RNA-seq. But where we did see differences and also mirrored what we had seen in the RNA-seq was when we looked, for example, at MHC class 2, where we saw significant increases in expression when the animals were treated with the P38 inhibitor. And we also saw loss of signals that we often associate with M2 or a more suppressive macrophage phenotype. For example, we saw significant reductions in ARG1, again, in the macrophages from bone lesions that were with animals treated with the P38 inhibitor. So we had, as I said, quite a bit of confidence in the RNA-seq data. But I think what we were more excited by is when we took the signatures that we were seeing in the macrophages from animals treated with P38 inhibitor. Basically, if we overlaid that with the TCGA data, what we could show is that patients that display a signature similar to the P38 inhibited signature, if you will, they actually were showing a much higher overall survival, again, suggesting that this is a better state to actually be in. And so given the significant changes we saw in macrophages and this patient data, we decided to first start to ask, are macrophages in fact important in the anti-tumor effects that we're seeing with the P38 treatment? And so to do this, we took, again, our animal model using the intracardiac injections to seed our tumor cells into the metastatic sites and depleted macrophages using both a cladronate and anti-CSF1 approach. And we're able to significantly limit the number of macrophages we could isolate from the bone, which is where we're doing the analysis. And what we found was that when we put animals now depleted of macrophages on the P38 inhibitor, we completely lost the anti-tumor effects of the P38 inhibitor, indicating that in some way, either directly or indirectly, macrophages were playing a critical role in limiting tumor progression within both the bone and the visceral organs. The data I showed you basically was that whole animal scale imaging, excuse me. So we went back and started thinking again, okay, how are the macrophages getting activated? How, in fact, are they limiting tumor growth? And when we went back to the RNA-seq data, I think I had already mentioned that we'd seen significant increases in gamma interferon signaling. Again, suggesting that gamma interferon might actually be important. And while it's a very pleiotropic cytokine, can affect a number of cells, is able to also affect macrophages. And so just to make sure gamma interferon might actually be important in this system, again, returning to that intracardiac injection, the first thing that we wanted to do was, again, ask, was gamma interferon important for the anti-tumor effects of the p38 inhibitor? And what we were able to show was that when we blocked, or I should say neutralized, interferon gamma with antibodies, we completely lost the ability to limit tumor growth with the p38 inhibitor. And this is not due to a cytostatic effect on the tumor cells. We've gone back and CRISPR'd out the interferon gamma receptor from the tumor cells, and they grow just fine. And so we really don't think this is due to a direct effect on the tumor cells, but rather somehow interacting with the macrophages. So gamma interferon can be made by a number of cells. Probably the three most prominent cell types people tend to think about in this context are natural killer cells and T cells, either Th1, CD4 T cells, or the CD8 T cells. And in data I don't have time to go through right now, we went on to show that in this particular setting, the anti-tumor effects of the p38 inhibitor do not depend on the presence of natural killer cells, nor of CD8 T cells. However, we saw a very different story when we went to the CD4 T cells. In fact, the anti-tumor effect that we see with the p38 inhibitor is mostly lost when we deplete CD4 cells. And so we went on, and again, in data I don't have time to show you today, that the CD4 cells are in fact making large amounts of gamma interferon in the presence of the p38 inhibitor. And so what we think is going on, and we still have some holes to plug here, is that p38 is leading to an increase in MHC class II expression, probably through gamma interferon, which is being released through CD4 T cells. And I think I mentioned that in the RNA-seq, and I should mention we have some data as well that it's also affecting trafficking of DC cells, and we're currently working on really what the impact of the p38 inhibitor is on the DC cells as well. But I think I mentioned that we also had the opportunity with the RNA-seq to isolate not just CD45 positive cells, but also the CD45 negative cells that were proximal to the tumor. And so again, in the interest of time and the fact that we're still working this out, I'd just like to mention that we think what's really interesting is that when we look at the CD45 negative cells, there are a number of different cell types present within the tumors, but there's a significant number of CAFs that are present that are expressing many factors that we would consider bone modulators. And so one of our hypotheses, and something that we're actively testing now, is whether or not these fibroblasts that are inside the tumor are not themselves directly contributing to the bone loss that we also see within this model. So I started this whole section of the talk out saying that really the goal of the work that we were doing with the RNA-seq was to try to understand not just the targets, but also really what the mechanisms were that were leading to the anti-tumor effect of p38, and the goal to push this curve to the right. And so we started again looking back at what we had learned in the context of the immune component, and really what else was in the system. And so when we started to look at what was being expressed by those p38 treated macrophages, most of the co-stimulatory molecules that one might think of were present, but we saw that there was one particular molecule that seemed to be completely absent from the system, and that was the OX40 ligand. And this was actually quite intriguing to us because the OX40 plays a very important role in the activation of T cells, both CD4 and CD8 T cells. Remember, we've already shown that it's CD4 T cells that are important for the anti-tumor effects of the p38 inhibitor. And so we wanted to ask, was it possible if we were able to actually goose this system, if you will, activate OX40 on our T cells, could we increase the efficacy of our p38 inhibitor treatment? I think a picture might be worth 1,000 words, and what you can see here is that the anti-tumor effects of the p38 are matched by the effects of an agonist against OX40, something that's activating OX40. And in fact, when we combine the treatments, that's the purple squares and the picture that's boxed for you in the lower right, we again further decrease the tumor burdens within these animals. And now, for the first time, have started to push this curve out to the right. In fact, we see significant increases in overall survival in our animals when we combine the p38 inhibitor with the anti-OX40 inhibitor. Now, I mentioned that OX40 can activate can help to activate both CD8 T cells as well as CD4 T cells. certainly in the context of p38 inhibition, the CD8 cells were not important in our system, but it didn't mean that they weren't important once we had used the OX40 ligand. And so to address this directly, we then went on to deplete CD8 T cells from our system. And what you can see is that, again, the anti-OX40 is as effective. In other words, it doesn't depend on CD8 T cells, suggesting that, in fact, the target for this OX40 agonist is, in fact, the CD4 cells. So when we started to think about this data, again, thinking about the clinical situation, to date, immunotherapy has, for the most part, failed in breast cancer setting. And in many patients, it's thought to be, a moderate to a cool tumor, doesn't really have a lot of neoantigens. And so the last question that we wanted to ask was, how effective would this treatment actually be if we did, in fact, have a CD8 antigen in place? And so we decided to kind of take a brute force here and move to OVA, which is admittedly a very strong antigen, but to introduce it into our tumor cells and ask whether or not, when we now had a CD8 antigen present and attempted to combine that with our p38 inhibitor treatment as well as the OX40 agonist, what impact would this have now on tumor burdens within our animals and the survival of these animals? And so here I'm showing you the survival curve on these animals. I hope you can appreciate the straight purple line at the top, and that is in fact the combination treatment of the p38 inhibitor with the anti-OX40 agonist with cells that are actually expressing a strong CD8 antigen. So we've actually been able to cure these animals now of metastatic disease. And of course, the ultimate test of really if you've created an strong immune response is whether you've been able to create memory. And so to test that directly, what we did was to take the animals that are on that purple line there that were still alive over 80 days after introduction of our tumor cells, and basically to re-challenge them and simply ask, do we have memory now? So of course, when we take naive animals and challenge them with the same tumors in their primary setting, these grow quite robustly. They're very metastatic and aggressive tumor cells. However, all of our animals, when treated re-challenged with the tumor cells, showed memory, and we saw no regrowth many months after this initial treatment, arguing, in fact, we have established memory. And so we're actually quite excited by these findings and are now working with our bioinformatics partners to ask, can we find subsets of patients that have predicted neoantigens? And because the hypothesis would be they would be the ones who'd most strongly respond to this particular combination of treatment. And with that, I'd like to finish with the most important slide, and that's the people that actually did the work. I've tried to mention previous members of the lab as I've gone through this, but really most of the shout out I have to give you with the senescence work now is Ganesh Raut, he's slightly up to my left. I'm in the bright colored jacket there. And all of the immunotherapy is from an incredibly talented postdoctoral fellow, Douglas Faget, who's slightly up to the right of me in that picture. And with that, I'd be more than happy to take any questions you might have.
Well, Sheila, that's a great lecture. Thank you for presenting the work. We do have a few questions. One question is, do you have any insight into the durability and resistance to the dual p38 inhibitor and anti-OX40 therapy?
So if we don't have the CD8 antigen in place, I think the graph that I showed you, we get, I think on average, we almost triple the survival in these animals. So durability, on that model is about, 3 times what it was. Clearly, when we have at least a strong CD8 antigen in place, these animals so far at 100% are cured.
Great. And there's a comment or question, why aren't we all undergoing anti-senescence therapy?
Yeah, that would be my answer, other than denial for aging, right? No, I think, this is an important question. People like to argue that everything seems to get better when you get rid of senescent cells, but there are clearly beneficial effects of senescence, not the least of which is its involvement in wound healing. And so I think we just, at this point, don't have a good sense of where senescence is a good thing and where it's a bad thing. And, even probably too much of the weeds to answer that comment is, what is the better approach? These senolytics to kill these cells, cynomorphics like the p38 inhibitors to modify them. I think this is an important area that has to be addressed before we all jump into a vat of anti-senescent therapy, I think.
Okay, there's another question here. What happens to overall cell dynamics when you kill senescent cells? Are they replaced with newer cells?
Yeah, that's another great question. So one of the issues is actually finding senescent cells in real time has been very challenging. So there are certainly within tumor models, these cells are cleared very quickly by the immune system, but what happens in a normal homeostatic situation isn't clear. So the NIH now has a U54 out to identify senescent cells across human tissues, across human age. And I think once we get that information, I think those types of questions can be answered. But at this point, we honestly don't know.
Okay, well, Nellie says that exercise is anti-senescent therapy.
I'm with her on that.
Okay, Rakesh Jain says, congratulations on this elegant work. Interferon gamma also affects blood vessels and may increase infiltration of immune cells. Have you looked at blood vessels after the approaches you've tested?
Yeah, so I mentioned that our RNA-seq approach lets us pull both, CD45 negative and positives. I kind of glossed over the endothelial cells mostly because we haven't done anything with them, but there are clear changes that when we treat with P38, they themselves show increases in gamma interferon signaling. There are other changes going on, and I'm going to be totally honest, Dr. Jane, we just haven't had time to go into that data yet, but clearly we're going to look at them.
Another question is, could you try some of these approaches on terminally ill human patients? Is that an ethical approach?
If you mean the P38 inhibitors, so we do have a grant now to put the MK2 inhibitor on board in the metastatic breast cancer setting. One of the things that we're trying to do with that is couple it with bone turnover. So we clearly see reduction. I think I showed that quite convincingly in bone loss in this case, our patients with tails. And when it comes to this particular drug, they have not been able to get a maximum tolerated dose in humans. So they've had human volunteers. So I don't really think we have an ethical problem with putting this in the metastatic setting, if that was the question that was being asked. As I said, we're seeing, at least in the models, as much efficacy with these as single agents as chemotherapy. So our hope is, at a minimum, we can reduce bone loss in these patients. At a maximum, we actually reduce progression-free survival.
All right. Well, I think those are the questions. If anyone has any other questions, I'm sure Sheila can respond to them by email. And I want to thank her again for taking the time to give us such an excellent talk. And we'll let everyone go off and enjoy the rest of the afternoon. Thanks, Sheila.
Thank you very much. And thank you, everybody. Have a great night.